Hi everybody, welcome to Dr. Manny's YouTube Learn Shops, and this is a continuation of the health assessment in an adult, and what we'll be reviewing is the musculoskeletal system. Now typically clinical manifestations associated with anomalies of the musculoskeletal system could be associated with swelling, edema, redness, inflammation, pain, joint stiffness, muscle strength, and the ability or inability to perform activities of daily living. So when we look at the assessment of the musculoskeletal system, the musculoskeletal system essentially assesses the skeleton, the bony structure, and the associated muscles. And we're looking for signs of disease. And typically, the examination occurs after the history has been obtained, as with all the sessions that we've had. Now, when you do a musculoskeletal examination, conventionally, there are two main techniques that are used, which is inspection and palpation. Subjective assessment is important because this can determine certain issues that the patient is experiencing. And as always, we follow with the interview, which deals with family history, past medical history, medications, lifestyle behaviours, which could put the patient or client at risk. And we always take note of their signs and symptoms, things like pain, numbness, tingling, burning, cramping, stiffness, signs which could indicate a decreased range of motion, any deformities, changes in their grip strength, and loss of muscle function. Questions that could be asked in respect to family history are: do your parents or siblings have any muscle, joint or bone issues? Who had the problem? When did it occur? How was it treated? What was the outcome? Because musculoskeletal problems with a family history tend to include issues such as osteoporosis, bone cancer, rheumatoid arthritis. In respect to past history, questions could include: have you ever had an injury or trauma, which could be a fracture? Have you had a stroke? Have you suffered from poliomyelitis? Have you had a bone or muscle infection? Do you have diabetes mellitus or parathyroid diseases? And if so, when did they occur, and how were they treated, and what was the outcome? Medication and nutrition history might be important as well. So therefore questions could revolve around: what is your daily dairy intake? What medications do you take? For example, it may be related to calcium and vitamin D. Women, any current or past oral contraceptives? Postmenopausal women, hormonal replacement therapy. In general, calcium and vitamin supplements, pain or inflammatory medications, muscle relaxants or steroids. All may have an influence on the musculoskeletal system. When it comes to lifestyle behaviours, which could put you at risk, an occupational history might be important. Questions could include in relation to: what work do you do? Does it involve repetitive motion, lifting, twisting? How do you protect yourself from injury at work? If it relates to hobbies or sports, how do you protect yourself from injury? Do you use car seat belts, helmets, if riding a motorcycle or playing football? What protective gear is utilised? Have you ever smoked, which is a risk factor? If yes, how many packs per day and for how many years? And what type of cigarettes do you smoke? Have you ever consumed alcohol, which puts you at risk of osteoporosis? And if so, if yes, how many do you drink a week? What type of alcohol do you drink? Some of the common signs and symptoms, or symptoms in particular, that relate to the musculoskeletal system are pain or discomfort, aching and stiffness, pain worse on movement, weakness, fatigue, stiffness, limited range of movement or motion, deformities, lack of balance or coordination, difficulty sleeping. Some of the equipment that's required when doing a musculoskeletal assessment could be gloves, a reflex hammer, a goniometer to assess range of motion, a tape measure to determine equalisation of limbs. The objective assessment in a physical assessment involves, again, vital signs, and the two techniques that are primarily used are inspection and palpation. And the rationale for utilising vital signs is to determine whether the patient is stable or unstable. Inspection, the initial inspection involves observing posture. And when you observe posture, you're observing standing with feet together. You observe the relationship between head, trunk, pelvis and extremities. And you assess for symmetry in the shoulder height, scapulae and the iliac crests. And the posture is important as well when the patient sits. The posture in an erect position, the head is midline above the spine and the shoulders should be at equal height. In the initial inspection, we always look at gait mobility. So you watch the patient as they walk across a room, you observe from the side and you observe from behind. The gait can predict a fall's risk. Walking is typically smooth and rhythmic, and the patient rises easily from a sitting position. Balance, you ask the patient to walk on tiptoes, heels, heel to toe and backward. You also ask the patient to step to each side and to sit down and stand. The Romberg test is done, and this is where the patient stands with feet together with eyes open, and then you ask the patient to close their eyes. And they should remain steady without swaggering or at risk of falling. Coordination is assessed by asking the patient to rapidly pat a table or alternate palm to dorsum of the hand. When it comes to assessing or inspecting and palpating the temporomandibular joint, and when you inspect, you look for jaw symmetry, any swelling, any redness, and really you want to make sure that the jaw is symmetrical bilaterally. Now, palpation, you place the finger pads in the front of the tragus of each ear, as indicated by the diagram. You ask the patient to open and close their jaw while you palpate. You feel a shallow depression. The mandible motion is smooth and painless. The muscles are symmetrical, smooth and non-tender. And the range of motion, you ask the patient to open the jaw as wide as possible, and you push the lower jaw forward and return the jaw to the neutral position. The jaw also is asked to be moved from side to side, 1 to 2 centimetres, and muscle strength can be assessed, and it should be 5 out of 5, or the maximum 4 in the muscle grade strength indicator, contraction against gravity and slight resistance. When inspecting the cervical spine, the patient stands, you inspect the cervical spine from all sides. You observe the side for concave cervical spine curvature, and the patient holds their head erect and the cervical spine is straight in alignment. When you palpate the cervical spine and neck, you're palpating from C7 to T1 of the spinous processes are prominent. You also palpate the paravertebral and trapezius and sternocleidomastoid muscles to make sure that they are fully developed and symmetrical and non-tender. As far as range of movement or motion of the cervical spine, you ask the patient to touch the chin to their chest, which indicates flexion at 45 degrees. You ask the patient to look up towards the ceiling, hyperextension, which will indicate approximately 55 degrees. You attempt to touch each ear to the shoulder without elevating the shoulder, which indicates lateral flexion, 40 degrees. You ask the patient to turn the chin to the shoulder as far as possible, and rotation should typically be around about 70 degrees on each side. As far as muscle strength goes, you ask the patient to rotate the neck to the right and left against resistance of your hand. And the muscle strength, under normal circumstances, overcomes the resistance. When we inspect the extremities, we're looking for general appearance. You assess for swelling, laceration, lesions, any deformities, the length of the long bones, the size of the muscles, and symmetry. You also assess for size and shape. So you evaluate both extremities at the same time to compare muscle tone and strength. Limb measurements, so you compare arm and leg circumference. You measure limb length on the forearms, upper arms, thighs, calves. You observe the knee height with the patient sitting. It should be symmetrical. On palpation, in respect to range of motion of the extremities, you palpate the joints for contour, size. You palpate for muscle tone. You feel for masses, bumps, nodules, or any deformities. And you ask the patient, is there any tenderness or discomfort? Simultaneously, you observe and palpate each joint while the patient performs active range of motion. So if the patient cannot do so, you carefully support the limb joint and perform passive range of motion. And you listen to or you feel the joint while the patient moves. If range of motion is limited, use a goniometer to measure the angled joint at its maximum flexion and extension, as indicated in the diagrams. When it comes to the shoulder, you compare both shoulders anteriorly and posteriorly for size and contour. You observe the anterior aspect of the joint for abnormal swelling. There should be no redness, no swelling, no deformity, no atrophy. The shoulders are typically smooth, symmetrical, and level. Each shoulder is at an equal distance from the vertebral column. On palpation, you stand in front of the patient, you palpate both shoulders. You note for any spasms, atrophy, swelling, heat, or tenderness. You start at the clavicle and you explore the acromyoclavicular joint, the scapula, the greater tubercle of the humerus, the subacromial bursa, the biceps groove, the anterior aspect of the glenohumeral joint, and the muscles should be fully developed and smooth. When you're assessing range of motion of the shoulder, you ask the patient to perform forward flexion, extension, hyperextension, abduction, adduction, and internal and external rotation. All movements should be fluid, meaning without any difficulty. The muscle strength, you ask the patient to shrug both shoulders, flex forward, upward, and abduct against resistance. The patient performs full range of motion movements against resistance. When you review the elbow, inspection for size, contour of both in extended and flexed positions. You check the bursa for swelling. The elbows are found to be symmetrical with no swelling. On palpation, you support the forearm and passively flex the elbow to approximately 70 degrees. You palpate the olecranon process, the medial lateral epicondyles of the humerus, always checking for swelling, nodules and tenderness. Findings should be that the elbows are smooth with no swelling and no tenderness. Range of motion of the elbow. In order to do this, you ask the patient to bend and straighten the elbow and to pronate and supinate the forearm by laying the forearm and ulnar surface on the hand of a table. You have the patient touch the palm and then the hand dorsum to the table. Flexion and extension are performed. Pronation and supination of 90 degrees is normal. Muscle strength is performed against resistance, and you ask the patient to flex and extend both elbows. When we evaluate the wrists and the hands, on inspection, you look for digit symmetry, colour, fingernails, palms, and the dorsum, and any anomalies. You palpate the patient's hands with your hands. You use the thumbs on each joint of the wrist and hand, and typically surfaces are smooth with no nodules, edema, or tenderness. When assessing range of motions of the wrist and the hands, the wrist can flex to 90 degrees and extension returns to 0 degrees. Hyperextension can go to 70 degrees. The metacarpopharyngeal joints flex to 90, extend to 0, hyperextend to 30. Muscle strength is typically performed against resistance, where you ask the patient to grasp 2 fingers tightly while you pull to remove them. Muscle strength is equal bilaterally against sufficient resistance. When it comes to the hips, on inspection, you assess the iliac crest, size and symmetry of the buttocks and the number of gluteal folds. With the patient lying supine and legs straight, look for swelling, lacerations, lesions, deformities, muscle size and symmetry. You look at the hips from an anterior and posterior view, and the hips are typically rounded, even and symmetrical. When you palpate the hip joints, iliac crests, muscle tone. You feel for any bumps, nodules, deformities, and you ask if there's any tenderness when touched. You feel for crepitus when moving the joint, and the buttocks are typically symmetrical. Iliac crests should be the same height on both sides. When assessing range of motion of the hips, you observe for full active range of motion of each hip. Flexion should be 90 degrees. They should be able to draw the knee to the chest up to 120 degrees. Extension should be at 90 degrees, abduction 45 degrees, abduction past the other leg to about 30 degrees. Internal, meaning medial, rotation should be 40 degrees, external lateral 45 degrees. Muscle strength, which applies pressure to the top of the leg while the patient flexes the hip. The application of the pressure to the side while the patient abducts the hip, as indicated in the diagrams. When it comes to the knees, inspection for contour and shape. You observe for swelling, lacerations, lesions, deformities, muscle size, symmetry. The knees are typically symmetrical and aligned with the thighs and the ankles. With palpation, the knees are flexed. You palpate the quadriceps for muscle tone. You palpate downwards towards the patella. You evaluate the patella and each side of the femur and the tibia. You palpate the joints with the leg flexed at 90 degrees. You feel for any bumps, nodules or deformities and ask if there's any tenderness. You feel for crepitus when moving the joint. Quadriceps are firm and non-tender. The joints are firm and non-tender. Range of motion of the knees. You observe for full active range of motion. You flex the knee up to about 130 degrees and return back to the extended position. There shouldn't be any discomfort or crepitus. Muscle strength is determined while the patient is seated, and you apply pressure to the anterior lower leg while the patient extends the leg. With the leg bent, you ask the patient to maintain that position while you pull the lower leg as if to straighten it. Muscle strength is equal, bilateral, and able to be overcome as far as resistance goes. When it comes to the ankle and the feet, you inspect for swelling, lacerations, lesions, deformities, symmetry, and toe alignment. The feet are the same colour as the body and symmetrical. The toes are aligned with the long axis of the leg. There is no swelling present. You palpate for bumps, nodules and deformities. You palpate the anterior and posterior ankle, which is the Achilles tendon, and the metatarsal joints. You palpate each interphalangeal joint and you note for temperature, tenderness and contour. And you always ask if there's any tenderness during the touching. And you feel for crepitus when moving the joint. When it comes to range of motion of the ankles, you observe again full active range of motion of the ankle, dorsiflexion 20 degrees, patient raises the toes towards the knees. Plantar flexion 45 degrees, the toes point downwards towards the ground. Inversion, the sole of the foot is turned towards the opposite leg 30 degrees. Eversion, the sole of the foot is turned away from the other leg 20 degrees, as indicated in the diagrams. When you inspect the thoracic and lumbar spine, the patient is standing. You look from the side for the normal S pattern. From behind, you note whether the spine is straight. You observe the scapular, iliac crest, gluteal folds, ensuring that they're level and symmetrical. You ask the patient to bend forward. You reassess the vertebra to see that they're straight and the scapula are equal in height. The spine should be aligned, both standing and sitting. With palpation, you palpate the spinous processes for bumps, nodules, deformities, and again ask if there's any tenderness during touching. You feel for crepitus when the spine is bent. Spinous processes are in a straight line. The paravertebral muscles are firm and there is no crepitus. When it comes to range of motion of the thoracic and lumbar spine, you again observe full active range of motion on both sides. You ask the patient to stand and bend forward and lean backward. And this includes lateral flexion, abduction on either side. You ask the patient to slide a hand on one side down the thigh and bend away from the midline towards the side. You repeat this to the other side. The patient should be able to perform full range of motion without crepitus or discomfort. Musculoskeletal disorders can be numerous. They can include tennis elbow, bursitis, osteoarthritis, Achilles issues, patella tendinitis, gout, Injuries obtained from sport. Some of the anomalies could be rheumatoid arthritis, osteoarthritis, epicondylitis, polydactyl, joint dislocation, carpal tunnel syndrome. Other disorders could include atrophy, ulnar deviation, which often occurs with rheumatoid arthritis, rotator cuff tear, which could be related to sports injuries, congenital hip dislocation, which an infant can be born with, joint effusions, osteoporosis. Other issues could include acute rheumatoid arthritis, ganglion cysts, bursitis, contractures, knock-knee syndrome, herniated nucleus pulposus. That's the end of the musculoskeletal session. If you found this of any value, please review it. This is a very extensive musculoskeletal assessment which takes time to understand. If you found this Dr. Manny Learn Shop of any value, please recommend it to your colleagues and your friends and subscribe for future Dr. Manny Learn Shops. Take care, God bless, and see you in other Learn Shops.